One.
Cool. Hey guys, Steve Oswald here again, physical therapist at Idaho Spine and Sports Physical Therapy. Thanks for tuning in. Today we are talking about carpal tunnel syndrome. This is a very common condition. About 7 or 8% of all of us will experience this at some point in our life. To be honest, it's probably the second most common self-diagnosed thing that we end up seeing, where any kind of numbness or tingling in the hands we kind of self-diagnose as carpal tunnel, but we truly do want to differentiate carpal tunnel from other things that may be causing numbness, tingling, or pain into the palm and hand region. So it's important for us to discuss a bit about what carpal tunnel is, where you typically have symptoms, what that looks like, risk factors, how that progresses, and then talk about how it's typically treated, because it's very common to have the surgical release, which we'll talk about, which has a high success rate, but then other options and what should be standard of care for that. So kind of to begin, kind of walking through what carpal tunnel is. The carpal tunnel, when we say carpal tunnel, is really referring to the anatomy. Carpal tunnel syndrome is the problem that's in that area. Carpal tunnel, most of us, I'm going to take my band off here, think of that area in the wrist being down here close to where we take a pulse. But the carpal tunnel itself is actually an area that's between this bony area here called your pisiform and then your scaphoid bone here, right? It's above where you flex. Where you flex is the bottom of those carpal bones, right? So that's the bottom border of it. And then the top border of it is kind of mid-carpal area. So this is the area that we're referring to with the carpal tunnel. Through this area, we have a lot of important structures that run into the hand itself. We have the median nerve, which is what causes the symptoms with carpal tunnel. Passes right through the center of it, and it's the most superficial thing that passes through that tunnel. So it's real close to the surface of the skin. And then we have 8 long tendons, kind of 2 layers of them that run all the way down into each of the 4 long fingers, 2 each, one on bottom, one on top. They help to flex the fingers here and at the top, okay? And those run all the way up into the rest of the forearm. And then we have 1 long tendon that goes into the tip of the thumb here, okay? So we have 10 things that pass through that space. So as you can imagine, it's kind of a crowded region, and so there's not a lot of space. And there's typically enough space for everything to move and glide appropriately. But if a problem arises in that space where it becomes compressed, the nerve is the key thing that ends up paying the price for it, okay? There's kind of 3 schools of thought on how this develops in the first place, where you get your symptoms. One is where we think that ligament that spans the surface of it acts like a roof that covers it all and keeps it down, that it maybe contracts down and gets tight. That's fairly rare, and that usually doesn't happen. Second thing is that usually these tendons, any of those 8 long tendons, you start getting a swelling of those tendons where they've been overused. So those flexor tendons, they have a synovitis in them, and they swell up. And that swelling from the inside creates a enclosed space within that whole compartment and puts pressure on that nerve. And that will start causing some of those symptoms. And lastly, we feel like the nerve itself is become irritated and lost some of its local blood flow to it, which causes changes within the nerve itself, causing the nerve to swell. And again, it has a covering as well. And that swelling from the nerve will create the symptoms as well. Any of those things can be happening. All 3 of those things can be happening at one time. The problem lies with a space, right? When that carpal tunnel is enclosed, right, and we start developing symptoms of carpal tunnel, the classic area that you will feel symptoms is from that carpal row, right, at that spot, and then through most of the area of the thumb, okay, and then the portion of the hand here, up and through half of that digit, and then everything in this space on the palmar side of the hand, okay? So all of this tends to go numb. Some people don't get a lot here, but you usually will always have symptoms in the first, second, and third, all the way down to the tips of the fingers, but only in the hand. We usually don't have loss of sensation in the back of the hand because different nerves will provide sensation there. And we typically have some areas of the thumb that are okay because of how the antebrachial cutaneous nerve innervates that area. And the rest of this is from your ulnar nerve, so on the other side. Now, occasionally you can have full hand numbness with this if that ulnar nerve is impacted too, but it doesn't pass through that canal. It's a different issue. But classically, carpal tunnel, it's only that area, okay? That's a key way that you can differentiate what's going on with carpal tunnel, if it is carpal tunnel, or if it's something else that's causing hand symptoms. If you have full hand numbness, it's likely not only carpal tunnel. If you have numbness that extends up from that region, there may be another cause, like a nerve may be entrapped further up in your arm, or you may have a pinched nerve. Again, we say pinched nerve, but there's nerve encroachment somehow in the neck, and that can cause symptoms down into the hand as well that mimic this. What we find is specifically, they did some studies on office workers who are the most prone to develop these things, and roughly 30% of office workers at some point will develop numbness in the hands, but when we test them, only 10% of people display symptoms consistent with carpal tunnel, and when we do the nerve testing, only about 3 to 4% of those actually have a compression. So again, when we feel numbness in the hands, it's not always carpal tunnel. In fact, only maybe 10 to 30% of the time is it actually carpal tunnel syndrome that's presenting with those symptoms. So it's important to differentiate what you're feeling, where you're feeling it, so that you're addressing it appropriately, because any things we talk about today, if it's not carpal tunnel, are likely not going to provide you with relief. Classically, these symptoms will come on at night. That is, in fact, if you're not getting night pain and only daytime pain, that's been shown to be a key differentiator that it's not carpal tunnel. So the presence of night pain is critical for this. The feeling of where you shake out your hands, it tends to make it better. We do find that people with more of a girthy wrist, where it's more of a round shape versus kind of an oval shape, where it's kind of just a little bigger here, tend to have more of a compression there, and that's a cluster of findings that we find is consistent with carpal tunnel as well. And those are the big things to look for. When we test you clinically, we want to look for a couple signs to determine kind of how severe this is, because the severity of carpal tunnel will dictate truly what type of treatment you need. This is one of those conditions where it is very algorithmic. Like, you present with XYZ, you need this intervention, and that should be what should help you. We find that about a third of people, this just goes away especially if you just modify your activity. But a third of people, even with treatment, do go on to have to need surgery. And so, there's a third of people to maybe 2/3 of people that need treatment, and we need to find the most appropriate treatment for you. When we're staging this, if you're only having night pain and symptoms will come and go, and it's mild and it's not growing in severity, we term that mild carpal tunnel. That tends to do well with bracing, and so we'll talk about bracing in a moment. If your symptoms are growing in intensity and you occasionally have symptoms in the afternoon or evening hours, which tends to be more consistent, and you have what's called a positive phalanx test, which is where if you have your hands like this and you just drop them down and you just hold that position for 1 to 3 minutes, which is terribly boring, but it would replicate your symptoms. If you hang out in that position and it starts recreating your symptoms, that's oftentimes a moderate level of intensity for a staging for this. But if you have constant pain, where it's unrelenting and not going away, and we start to see muscle wasting, so that muscle right here, the base of the thumb, we call it your thenar muscles. This right here, that muscle group is one of the few muscle groups in the hand that's impacted by that median nerve. It provides the highway to work that muscle, and so you do see weakness there. So if you see weakness, and especially the muscle starting to go away, you simply just looking at both of your hands and comparing the two, you'll see a visible difference with the muscle mass. Once we get to that stage of atrophy, and we have constant pain especially, that we term severe. With severe carpal tunnel, surgery is the indicated option, and we'll get into surgery again at the conclusion of today. But once it hits that point of atrophy, it needs to be addressed immediately if it hasn't been already. So that's kind of what we should expect with carpal tunnel. The symptoms, how we stage it. by far the most important early intervention to implicate if it is carpal tunnel is going to be night bracing. Now, there's various levels of evidence for certain things working, but the standard of care is suggestive that with mild to moderate level of carpal tunnel, wearing a neutral wrist splint is, especially at night, throughout the night with sleeping, is the first line of defense that you want to take with treating this. Okay. So what that looks like, I literally just picked this up yesterday from Walgreens. I mean, it's you can find them everywhere. You just want something that is, again, most wrist splints that you'll find in the store are neutral wrist splints. You just do not want ones where it brings your wrist back like this, or is cocked forward or any given angle. You literally want it to be flat, okay? So if I pop this on, again, this is a left-handed brace, okay? You can see how my hand is kind of in a straight position, okay? Or like that. And when I strap it on, I want it to be snug, but not too snug, right? Because this is a compressive problem. Because the goal is not to necessarily provide stability or support, it's to just keep the wrist in a neutral position while you sleep. The reason that we have night pain compared to daytime pain with carpal tunnel is that when we sleep, we just have the tendency to let the wrist flex and just kind of stay in that prolonged position. So there'll be times when you just find yourself here and it will start causing symptoms. But when we have just this light brace where it puts you in a neutral position and you sleep with that, I cannot bring my wrist into a flexed position to start aggravating symptoms. So that just that prolonged period of time where the wrist itself is neutral offloads that area. It allows fluids to be kind of moved in and out of that area to reduce the pressure that may be surrounding the tendons and nerve itself, and reduces the irritation that's driving that fluid in the first place. So critically important that you, with true carpal tunnel, that you are starting with a night splint where it's neutral. Again, if you're not doing that with carpal tunnel, it's not that you won't get better. You have a 1 in 3 chance of getting better if you do nothing. But if you are not wearing your night splint with all the other activities that you're doing, you're just not getting the most out of your treatment. Okay. Have we had any questions so far about that? Have we had any questions about wrist splints? Again, you can buy these everywhere. I mean, anywhere that has a drugstore, just go to the area where they have wrist splints, knee braces, usually athletic tape and stuff like that in the drugstore, in the drug area. That's, I mean, a couple bucks, 15, 20 bucks, I mean, should get you what you need. It doesn't have to be fancy, doesn't have to be cool, doesn't have to be colorful. None of that matters, right? What matters is that it's just neutral. We do find that prefabricated or just off-the-shelf ones like this, generally speaking, work as well as a custom orthosis where someone makes it and manufactures it for you. When you would want to pursue getting a custom orthosis is if you are still having symptoms after using the night splint. So this is first line of defense, okay? So night splint, okay? That's standard of care, number one thing to do. Night splint, try that. Do that for a few weeks to see if your symptoms resolve with just night splinting. If it does not resolve with night splinting, it's kind of going on to stage 2, right? Where not necessarily that it's moderate intensity, but stage 2 of approach, where you need to ideally at this point start wearing your brace more frequently throughout the day. So it's not just night, you're also using it during activities throughout the day. And you need to ideally probably pursue additional treatment modalities. And so I'll talk about things that we would do in therapy that are appropriate, but there are that is typically the key route to go if it's not resolving with a night splint. Some people will do better if they get a custom orthosis at that point. So if the night splint with something off of the shelf is not effective, you can pursue a custom one to fit you better, but usually the daytime is more warranted. Physical therapy is the treatment of choice at this point, and surgeons will tell you the same thing. So at this point, doing activities interventions to improve the health and mobility of that area to address that compressive issue is warranted. And it's warranted sooner rather than later. Again, this is not something that you want to delay, especially if it has been going on for some time, because the clock is technically kind of ticking with this. If symptoms have been persisting for more than a year, you start to run into trouble with treating this thing conservatively without surgery. So it's important that you trial the night splint and see how it does, and then immediately pursue other interventions if it's not resolving. In therapy, there's a host of interventions that we do to try to improve the health of this area. Luckily for us, we have brand new guidelines for this too, to kind of clear the air of what we should be doing, both as therapists, but also as healthcare practitioners, with what works well, what do we not really know about that works well that we're implementing, and what should we not be doing to try to make this better. I'll kind of start with some of the not, like let's start with the bad, the good, the great, right? But what we find is that using magnet therapy, starting off with the weird stuff, but that's out there, like literally using magnet therapy in this area has been shown to be not effective, and the current guidelines say don't do magnets. Okay, that may sound strange, but if you come across it, it's not doing you any good. You're frankly probably wasting your money on it. The evidence just isn't there. You're better off pursuing a different type of intervention. There's another type of treatment approach called iontophoresis, where you use electrical stimulation to implement drugs into that area, specifically anti-inflammatories. That's not shown to be effective in this area. Using thermal ultrasound, so an ultrasound machine that kind of warms the tissue in that area, has been shown to be ineffective. And probably the most common thing that's implemented as a modality to treat carpal tunnel, especially now because it's kind of emerging as an exciting tool, is using low-level laser. And what we've found consistently with the evidence for treating carpal tunnel with laser is that it's really no more effective than placebo. And so it's unfortunate that that's the case, because it can be promising with other things. However, with carpal tunnel, laser does not seem to be a great option, at least according to our guidelines. Things that likely will work and have some efficacy for helping are what are called nerve mobilizations. So getting that median nerve to kind of glide through that area more efficiently. This can be helpful. For a small subsection of people, there is some median nerve scarring or hypomobility moving through that area. For most people, they don't. It is a space problem, but the way it passes through, it oftentimes doesn't get bound up. It's just compressed down upon. But you can do these mobilizations to make it glide more efficiently and not be as compressed. The way we would do just a simple median nerve mobilization, starting kind of off easy, because again, you can actually overdo it with these and aggravate your symptoms because the way it puts pressure directly into that area that makes your symptoms, is if you bring your hand kind of up by your side. So this is our median nerve mobilization, right? If you bring your arm kind of up in this kind of field goal position like this, and keeping your head straight, drop your hand down like this. So you're in that kind of extended position, right? And then extend your arm out like that until you feel kind of a strong stretch through the arm, or you may even get some symptoms in the hand. Now, what's important about this mobilization when we're here and doing this is we're not going to treat it like a stretch, like we're stretching a muscle where we're sitting here holding it for 30 seconds or so. That's really going to be irritating that nerve. Nerves do not like to be tensioned, but this little bit of tension that we put into it may help it glide better. But if we're here, extended, come out, only hold for about a second, and then come back out of it, right? Waiter holding a plate or something, right? And then drop it out and come back up, okay? Just repeat that roughly 10 to 15 times, okay? Take a break from it, shake it out, because shaking it out usually helps, right? And then you can do another round. I usually suggest no more than 30 total repetitions of this in any given setting. And so you can choose how you want to break that up, like 3 rounds of 10 or 2 rounds of 15. It's equally effective if you do both. Kind of depends on how tired your arm gets up here. But we don't want to do terribly more than that, because that can start to be irritating to that nerve if we just repeatedly put tension into it. So it's one of those things where we want to live by this Goldilocks rule of not too much, not too little, not too hot, not too cold. We don't want to necessarily not do it, because doing an intervention like this can be helpful. So some is better, ideally, than none, but too much is too much, and you can also worsen those symptoms. So that's one treatment approach. Again, there's limited evidence for that, but it seems to be helpful for a good subsection of people. The second, and frankly most important as far as exercises are concerned, are doing things to improve the muscle length and gliding of these flexor tendons, these ones that I talked about in the hand that go all the way down into the fingers. Because again, when we talk about a compressive problem in that space, we want to make sure that everything is moving well, right, and kind of exchanging and moving fluids out. So we want to ensure that any kind of limitation with that extended position is resolved. So doing something like a wrist extension stretch. Okay, there's multiple ways that we can do this. Pick the one that's most comfortable for you, but you can, extending your fingers is the important aspect here. Keeping your fingers straight, extending your hand out in front of you like that. So we're trying to pull our fingers and our wrist back to get a stretch there. Now, sometimes this can be still an aggravating position for that carpal tunnel because, again, it will typically compress more all the way flexed, and it can still compress the opposite direction too, so you may get symptoms there. But feel it out, elbow straight, everything extended. You can do that the opposite way, where it's up. Some people find that to be more easing in that position. And some people like to do both at the same time. And sometimes this is the most efficient stretch because it's not uncommon, in fact, almost more common than not, that if you have carpal tunnel on one side, most often your dominant side because of just use, you oftentimes will have some on your other side too. So if we have both, we can stretch both at the same time by doing a prayer stretch. So fingers together, make sure your palms and your hands are stuck together like imagine they're super glue. Keep it close to your body and drop it down like that into that position. So your fingers are extended, your palms are together, but you're extended backwards. Now with this one, we do want to stretch it in the traditional sense where we're holding it for roughly 30 seconds to a minute, doing minimum 2 rounds, ideally maybe even 3 to 4 rounds of stretching to truly improve that muscle length to ensure that that mobility through the wrist and into the fingers is addressed. Okay. We do want to watch for those symptoms though. If you are having increased symptoms into the hand, that's an important differentiator that you need to maybe try a different way of stretching it to see if you can stretch into that without causing those symptoms. And if you can't seem to find a way to do that stretch without replicating those symptoms, that's a good cue to talk to your PT or your healthcare provider about what you can and should be doing, because we don't want to be manifesting more symptoms when you're trying to address it. Okay. The second way to get those tendons moving besides just stretching are doing a set of exercises that we call tendon glides. Now these get kind of weird with hand positions, and so I'm going to go through these kind of slow and a couple times. But every one of these hand positions gets a different set of muscles and tendons moving through the palm of your hand. So it's important to do the whole sequence so you're getting all of that moving well. The first position and the starting position is always with your hand and everything straight, okay? And we're always going to come back to this straight hand position between each movement. With carpal tunnel, again, if you look on the internet and you look up tendon glides, there's usually 3 to 4 different movements. With carpal tunnel specifically, there's one movement within the tendon glide sequence we don't want to do. So I'm going to show you the one not to do first, and that's this. Okay, we call that a lumbrical position. Okay, this is commonly done. In fact, a lot of folks will do this in treatment, and it's well intended. But however, what we know in this lumbrical position like this, specifically if we're here, like in this position, and imagine like picking up a heavy book, like that type of motion. That motion pulls some of the muscles that are deep in the hand, called your lumbricals, down and forward, and actually encroaches from the bottom up into that carpal tunnel. It actually reduces that space a little bit. So while it's well intended to do these tendon glides, to do this motion, this is a provoking position. And so with our tendon glides, we don't want to do this or this, okay? But we're going to do the rest, okay? The first one that we're going to do is where we do a hooked position. So your hand and fingers are bent like that, okay? And you're here. So it's that motion, okay? You're keeping the top knuckle straight. okay? But you're bending the top ones, okay? So that's position one, the hook position, okay? The second is going to be a flat hand position, so you're here, okay? You're going through that motion, okay? So I'm only bending at this top knuckle here, but keeping the bottom one straight, okay? And the last one is just a normal fist, okay? So you pull them all the way in, and thumb goes over the top, open all the way up, hand goes down, thumb over the top, okay? Like that. So those are our three that we're going to do. I know that seems very simple, but each of those movements gets a different set of tendons moving through that space, so it moves well, okay? The tendon glides, again, are one of the more important exercises that you can do for carpal tunnel. Other things that we know work well, we've got non-thermal ultrasound that can be effective for that area, so where it's a low enough setting that it still kind of mechanically changes or provides some input to that area to basically help to change that tissue and calm it down. We do know that there's actually good evidence for just the use of superficial heat in that spot, so literally like a moist hot pack or something in that area actually does have good evidence that it can be helpful in this area because of the way it helps heat and normalize the tissue in that area. And lastly, using what's called interferential current. It's similar to TENS. A lot of us have heard of TENS units where it's electrical stimulation using pads. There is evidence of using interferential current in this region to help just normalize that area, calm tissue, improve, well, at least stimulate some of those neural components. So those are treatments that could and should be applied within the therapeutic setting to address carpal tunnel. Okay. That's kind of a basic treatment approach. Again, there are oftentimes more things that can be done, and that's based off of your kind of unique presentation. It's not uncommon that we move well upstream and address things not just in the wrist with this, because this is a nerve issue and it's oftentimes affected by other components upstream. In fact, what we find is that people with some sort of nerve encroachment, like a stenosis or even like a bulge disc or any of those things that we think of as nasty things, which are quite normal still, and maybe you don't even feel, which is normal, putting pressure on those nerves where it's not to the level of symptomatic actually increases your risk and severity of developing carpal tunnel. So an issue up here, while you may not feel it, actually increases the problem down here. So we may actually do things to improve neck mobility and motion and spacing in the neck, the upper arm, these areas where it's got to pass through first in order to kind of truly treat the foundational issues and some of the risk factors associated with that. So the whole system can and should be involved. It's important to adhere to a few different educational components with this too. This is very much related to repetitive use of tools, repetitive cold exposure, and mousing, so using a mouse. And so when attempting to remedy this, it's important to address those causal factors that may be present in the first place. So switching your mouse to an ergonomic mouse, which is putting your hand in a neutral position, so the mice where you literally got your hand around it like this, and you're clicking this way versus the traditional sense, okay? Keyboarding has not been shown to be a risk factor, even though we all kind of feel like that should be the case, but it's been pretty heavily researched, and actual keyboard use is not a risk factor for carpal tunnel. However, if it's symptomatic, we just want to be watching the keyboard intensity, right? Don't be hammering on it. Like, it's actually important. I know that sounds strange, but that's what we see. It's just like, be nice to your keyboard, soft strokes, because more aggressive strokes may keep it symptomatic, okay? Make sure that your workstation is ergonomically fit, elbows right by your sides, the screen placed just right in front, eye level, 18 inches in front of you. Everything should be neutral. Your hands should be able to remain flat and not extended as you're typing. So all those things should be implemented in your workstation, especially if you're symptomatic, because it's likely that some of those things may be contributing to it, and it may not go away as quickly if those causal factors are not addressed. And again, I mentioned cold exposure too. We're coming into a warmer time of year now, which is nice, but cover your hands in the wintertime, because that cold exposure seems to be, again, related to some of this. It's not uncommon to have a nerve test done to diagnose this. Now, Again, there are a cluster of clinical findings that we can already use to pretty easily discern if this is carpal tunnel or not, but the true staging is best done with a nerve conduction velocity test, is what it's called. And that is frankly kind of, it's more necessary if we suspect that there is a moderate and ongoing into severe level of carpal tunnel. Mild carpal tunnel, where you're only getting pain at night, goes away during the day. It's not warranted to get this test done. It's mild enough and frankly most easily clinically diagnosed, and you don't need to go to that step and frankly cost to diagnose. That nerve conduction velocity test is truly warranted to get a good diagnosis and know the amount of compression that's in that area and the staging to make surgical referral and or outcomes better. So if we're thinking surgery, then it's appropriate. If surgery is not truly on the table, then it's frankly not necessary. Moving on to surgery though, again, it is still technically the gold standard for treatment for carpal tunnel because people typically do well long term, but surgery does have its risks, has its risk of exposure, even though most of these are mini open or arthroscopically performed, where they go in and they just literally transect that transverse carpal ligament, where that covering, that roof, they just cut it, right? So it reduces the space problem. For some people, that's enough. Again, if this has been ongoing for a long time, sometimes it still doesn't help though. The key factors that the American Academy of Orthopedic Surgeons say means you need surgery are if you've had symptoms for greater than a year, right? And they're constant. So you have constant numbness in the hand for a year. You have tried other non-surgical treatments and failed them. And the last was it's severe, either diagnosed by that nerve conduction velocity test, or we're starting to see that muscle atrophy here. So it's, again, constant, greater than a year, muscle atrophy, or it's diagnosed as a severe form, and you've tried these other things we've talked about, and it hasn't worked for you. That's what the surgeon's recommendations are. And so if all those being the case, it's a no-brainer. Go get that surgery. That's really kind of the most important thing to assist with getting it better. Long-term outcomes for that typically are pretty good. There's oftentimes, on average, about an 8-week recovery period. At least that on average, that's what workers getting back to work take to get back to especially keyboarding. So there is a bit of a downtime afterwards. So if you're looking for a short-term fix, you got stuff coming up, surgery is definitely not your best option. You would try all the things we talked about first. But that's kind of the approach. That should be the approach for finding if carpal tunnel is what's going on for you, how it should be medically monitored and approached based off the best available evidence and how we treat it here at ISSPT, and what we can do about it when it takes going to surgery. Okay. Have we had any questions come up? Man, I must have been too thorough today. So that's what I had prepared for us today regarding carpal tunnel. I wanted to be sure we talked about treatments, talked about surgery, talked about conduction tests, what's causing it, and how you can get better. So I feel like we've done a good job doing that today. If you have questions that come up after reviewing this, if you weren't able to catch us live today, post them in the comments and I'll get back to you soon. Otherwise, we got an awesome week coming up next week. I'm going to put a plug in. We've got vertigo on Tuesday, so we'll be talking positional vertigo. It's going to be great. It's a common condition, and we love treating it here. It's one of my favorite things to treat. It's a slam dunk treatment. We can usually fix you pretty fast if it's true positional vertigo. So I want to talk about vertigo. Thursday is all things neck pain. It's going to be big. That one will probably be a good long one. So come with your questions. We're talking neck pain on Thursday. And Friday, equally as important, super common plantar fasciitis. So back-to-back days. Friday will be plantar fasciitis. So come with your questions. Sign up. Tell your friends. Have them join the group. We look forward to educating you guys. Thanks.